Hi guys, good evening and welcome to the 8th lecture in our NSTS webinar series. Thank you all so much for joining us tonight. So just a couple of practical points about the lecture this evening. Number one, your cameras and audio are all off, so don't worry about that. And secondly, so if you just make sure to pop questions in the Q&A window rather than the chat, because that might not be checked. And we'll have some opportunities to answer questions as we go through this evening, and we can have some questions at the end as well to mop up any that we haven't had a chance to answer during the presentation. So onto the lecture itself. So tonight we're very lucky to have Mr. Aminder Singh teaching us about vascular surgery. Aminder is an academic clinical fellow in vascular surgery at the University of Cambridge, and he is a vascular ST2 in the East of England region. He's also the European and Venous representative for the Rouleaux Club, which is the vascular surgeons trainee network, for those of you who don't know. So without further ado, I'll hand over to Aminder, and I hope you all enjoy the lecture.
Thank you very much, Lawrence. So welcome to our lecture on vascular surgery. It's going to be a bit of a whistle-stop tour, but we'll be focusing mainly on the acute conditions that you might face as a FY1 on the ward or during the vascular surgery take. So as Lawrence alluded to, it's going to be a very interactive session, so I've got quite a few cases to go through, but the main conditions I will be focusing on today will be acute limb ischemia, peripheral arterial disease, aortic aneurysms. Then we'll have a bit of a pop quiz at the end about leg ulceration. So the presentations we're going to cover is the acute abdomen, leg pain and swelling, and wounds of the lower limb. So firstly, acute limb ischemia. So what is acute limb ischemia? Well, acute limb ischemia is an acute decrease in arterial perfusion, which threatens the viability of a limb. This can be upper or lower limb, and it can have a history of any time period up to 14 days. I'm sure everybody knows how to take a history. A vascular surgery history follows exactly what you've learned in medical school. But in terms of the specific things that we want to know the exact time of onset of the symptom. When did the pain start? When did the patient notice something? Minutes from their admission to the emergency department. Do they have any change in sensation? Do they have any change in motor function? These are very key things to elicit. What about preceding symptoms? Did the patient have palpitations before this started, indicating there may be atrial fibrillation? Was there any chest pain, suggesting that an acute MI may have taken place? Or does the patient have back pain, abdominal pain, which suggests that there may be some history of aortic dissection? Just ensure that in their drug history, you figured out if they're on any anticoagulation or if they're on an antiplatelet, and get a general idea of their functional status in terms of how is their ability to perform their activities of daily living. Would they be suitable for intervention? So in terms of your examination, all you really have to remember specifically for this is the 6 Ps. So these are the 6 Ps of acute limb ischemia, which is pain, pallor, which is whitening of the skin, polar, or perishingly cold, which is when the limb goes cold, pulselessness, paralysis, and paresthesia. Paralysis is a very late sign and usually a pretty bad sign. So how do we classify this? We use something called the Rutherford classification in vascular surgery when we describe an acutely ischemic limb. This may be something that's just beyond the scope of your medical school finals, but it's good to know this for when you're speaking to a vascular surgery registrar on call, for example. Rutherford type 1 is a viable limb which is not threatened. A Rutherford 2A is a limb which is salvageable if you initiate some prompt intervention. So these patients will usually have some sensory loss, which is usually quite distal. A Rutherford 2B is when the limb is salvageable, but only with immediate revascularization. These patients will often have significant sensory loss and the beginnings of motor function loss as well. Unfortunately, if you leave these acute limbs long enough, you'll end up with a Rutherford type 3, which is irreversible damage through significant damage to muscle compartments and nervous tissue, and these limbs cannot be salvaged. So I like to think of my investigations in a system. I always do this when I present my investigations. So I usually like to do baseline bloods, bedside investigations, imaging, and then some special tests. With regards to this acute limb ischemia, a full blood count is useful. Urea and electrolytes to look for acute kidney injury, potentially from rhabdomyolysis, a coagulation screen as a baseline, and of course a group and save to prepare for theatre. An ECG is a bedside investigation, will tell you whether they're in atrial fibrillation. And then we can move on to imaging. There's usually enough time to get imaging before we have to do some kind of intervention in these conditions. Just as a bit of an overview, you can have different types of angiography. So you can have CT angiography, where you inject contrast through a vein and take a CT scan when the contrast has reached the arterial system. An MR angiogram, which is the same concept, but use an MRI instead. Or a DSA, a digital subtraction angiogram. This is when you do traditional angiography, which is intraluminal, injection of contrast, and you take X-rays whilst you're doing that. After you've intervened, to complete your investigations, you should do a CT aorta to have a look for any proximal disease, such as a thoracic aneurysm, an echocardiogram to look for valvular heart pathology, and a thrombophilia screen to look for anything that makes you procoagulable. The key ones to remember are looking for antithrombin 3 deficiency or antiphospholipid syndrome. In terms of what causes acute limb ischemia, well, there's those causes within the lumen, those within the vessel wall itself, and those that are external to the vessel. Within the lumen, you'll have an embolus. Within the vessel wall, often you have an atherosclerotic plaque, which is vulnerable, which ruptures, and that can cause an acute in situ thrombosis. Trauma can lead to damage to the blood vessel, which can compromise blood supply distally. Or you can have a dissection. A dissection is where you have a tear in the intima of the vessel wall, which leads to a false channel. In some situations, this false channel can actually obliterate the true lumen and cause an acutely ischemic limb. So how do we manage these patients? All patients who are acutely unwell need to be managed using the airway, breathing, and circulation pathway. You want to get help, you need to get a vascular registrar or a consultant down to help you if you possibly can. And then in terms of how do I approach management of conditions? Well, I use a conservative, medical, or a surgical approach. A conservative approach for this would be a patient who has an irreversible damage to their leg, Rutherford type 3, who has got multiple comorbidities and will not survive an operation. So they would be palliated and for symptom control. A medical intervention, we would start off anticoagulating these patients. We usually use unfractionated heparin, which we would give initially as a bolus of 5,000 units, or some people would give 70 to 100 units per kilogram. This is then followed by a maintenance infusion. Heparin's got a really short half-life, unfractionated heparin, which is why we like to use it, because we can anticoagulate, stop the heparin infusion in time for theatre. Thrombolysis is also an option with tissue plasminogen activator. This is not systemic thrombolysis. This is thrombolysis through a catheter, which sits just above the area of concern. So this is an interventional radiology procedure. You'd use something like alteplase or teloplase. Surgical intervention, well, you can perform an embolectomy. Many of you will be sort of familiar with this technique. You enter the artery itself, you put a catheter down beyond the embolus, you blow a balloon up, and then you pull it back. It's called a Fogarty catheter. And that can help you clear the embolus. Now you can do an endovascular version of this. So you can do aspiration, embolectomy, and thrombectomy. You use endovascular approach to use a catheter which can actually suck the clot up into the catheter. And that's another way of performing this. For those patients who've got irreversible ischemia for the Rutherford type 3, unfortunately, a primary amputation may also be an appropriate first management strategy. Okay, so let's go on to the first case. So you're the FY1 on the ward, on the vascular surgery ward. You've got a patient who's just came in with an acute limb ischemia on the right side. They've had an embolectomy done in theatre with a very good result. The nurse has asked you to come along and see the patient because they've got significant right-sided leg pain. On your examination, you find that they've got tenderness in the calf. They've got pain on passive flexion of the muscle groups. The leg is quite tender and it's pretty tense, but you're confident that you've picked up a pulse in the right dorsalis pedis and posterior tibial arteries. So can we have the first poll, please? What is the diagnosis? We'll just wait for all the answers to come through. Okay, so 42% of you went for compartment syndrome, 36% for DVT, and 16% for a further embolic event. So all of these scenarios are actually possible. So this is a single best answer question. In this situation, after revascularization of a leg, one of the biggest emergencies you need to rule out is compartment syndrome. In compartment syndrome, you have reduced blood flow from the acute limb ischemia. You then get ischemia of your muscle groups. This ischemia leads to increased anaerobic respiration. You get production of oxidative species, free radicals, which cause increased capillary permeability. There is protein leak into the extracellular fluid, which changes the oncotic pressure and causes edema. The edema is within a fascial compartment, which is unable to expand, so the pressure within the compartment increases. This increased compartment pressure then leads to further reduced blood flow, and then you enter this vicious circle. What is the definitive management of compartment syndrome? The next question, please. Excellent. So we had 89% of you went for fasciotomies, and that's absolutely correct. That is the definitive management for this condition. So if you think about the leg itself, there are 4 compartments. You have anterior, lateral, deep, and superficial posterior. You can enter both of those, all 4 of those compartments through 2 incisions. You dissect out the fascia, get a pair of scissors, open it up and down, and this allows plenty of space for the muscle to swell into. If this is not performed urgently, the muscle can die, and then you will then unfortunately end up with a useless leg, which will make the patient very sick and likely require amputation. So that's a whiz through acute limb ischemia. So just to summarize the key points, the things you really need to take home, remember the 6 Ps. They will be something which should be stuck in your mind for when you are on an acute vascular take. You need to think about anticoagulating the patient, and you need to escalate this patient. And remember, time is muscle. The longer it takes to get anything done, the more muscle death and irreversible damage will occur. Is there any questions at this point in time? Or do you want me to carry on, Lawrence?
No questions just yet. I'll just give sort of 10 seconds, see if, oh, yeah. Okay, yeah, one question. Is there any conservative way to rule out compartment syndrome?
So it's a very interesting question. So in essence, with good confidence, no. And the vascular surgery teaching is if you suspect compartment syndrome, clinically, you should go ahead and do fasciotomies. Some people will perform fasciotomies before they revascularize the leg to see what the compartments look like and to see what the muscles look like. There's no reliable test. So you can send off a total CK, so creatinine kinase. And sometimes in very small amount of places, usually in the intensive care unit, you can do compartmental pressures, but they are not very reliable. And most vascular surgeons will rely on their clinical instinct. If you think about compartment syndrome, you should do fasciotomies. Okay, great.
And someone's asked, are there any guidelines on what anticoagulation that we should follow as an F1?
Sure. So in the acute setting, unfractionated heparin is what we would give. Now there are different trust protocols for the heparin infusions. Once the patient's recovered, they will need to be anticoagulated long-term on oral anticoagulants. And usually the one that's licensed for arterial thrombosis is warfarin. The DOACs are currently unlicensed.
Okay, great. And just one last question before we move on. Oh, something's just popped up and got in the way of my question box. So what happens after fasciotomy? Are there any sort of complications or long-term effects?
Yes, it's a good question. So when you're performing your fasciotomies, there's nerves that are nearby. So you've got your common perineal nerve, which slings around towards just your hip fibular head. You need to try not to rupture those if you can. Obviously, if you do damage those nerves, they will give the subsequent problems with paresthesia and foot drop. But once there's not really much morbidity from lower limb fasciotomies. So you leave the compartment open and you would just close the skin on the top when it's possible to do so. You would not close the fascia again. So there's not really much long-term sequelae from lower limb fasciotomies. That's not the case with fasciotomies elsewhere in the body.
Okay, great. Let's crack on.
Okay. So next we'll move on to peripheral arterial disease. So this is really the workhorse of vascular surgery at the moment. Peripheral arterial disease is defined by an interruption of blood supply to the lower limbs, either due to a stenosis or an occlusion of a vessel. It affects far more men than it affects women, which is similar with any cardiovascular disease. And by far the most common cause is atherosclerosis, so buildup of plaque inside the artery, leading to luminal stenosis. Other causes which you may get asked about in your exams are things like vasculitis. And most commonly, they'll talk about Berger syndrome, also known as thromboangiitis obliterans. And this is commonly a young patient whose significant smoking history leads to an inflammatory type vasculitis in the lower limbs, which gives them claudication and such forth. So the risk factors. So remember these risk factors for vascular surgery because they come up quite a lot. You need to ask about smoking, ask about hypertension, whether or not they've got a dyslipidemia, if they've got diabetes, and whether they've got a family history of any cardiovascular problems. So firstly, we'll talk about intermittent claudication. So this is defined by reproducible cramping in the lower limbs on exertion, relieved by rest, and then the distance is reproducible. So they should be able to define the claudication distance, and then the patient will tell you that it's relieved by a period of rest. How do we investigate this? Well, a full blood count, urea electrolytes, and an LFT, but we'll add on a HbA1c here as well to look for diabetes, and a lipid profile to ensure there's no familial dyslipidemia. We'll talk a bit about ankle brachial pressure index. So this is really useful, especially in the community, to see what's going on with blood supply to the extremities. You can do the blood pressure at the ankle and the blood pressure at the brachial artery, and then it's the ankle blood pressure systolic over the brachial blood pressure systolic, and it gives you a number. And that can help guide us in terms of exactly how much difference there is between the upper limb and the lower limb. And an intermittent claudication will usually give you a value of about 0.8 to 1. A value of over 1 can suggest you've got calcified blood vessels. You can do a duplex ultrasound scan. So a duplex scan is a combination of B mode and Doppler, and it's an ultrasound scan, which we use quite a lot in vascular surgery because there's very nice images of the vessels. But that would be the first protocol because it's non-invasive. And angiography can also be considered here, as we've discussed before. In terms of the symptoms usually follow an occlusion or a stenosis a level above. So if you've got an occlusion or stenosis of your distal aorta and your iliacs, you'll get buttock and hip claudication and everything below. If you've got a problem with the iliac arteries, you'll get thigh claudication and everything below. And a problem with the superficial femoral artery, you get calf claudication. So that's how this usually works. So how do you manage these patients? Well, conservative management is really important here. You have to get these patients to stop smoking, and you need to get them to do exercise. So the NICE guidelines recommend supervised exercise therapy as a first line intervention, which is proven to have very good benefit. You want to start these patients on an antiplatelet if they already aren't on one, so clopidogrel or aspirin. And you want to make sure they're on a statin as well. We usually favor atorvastatin 80 milligrams for secondary prevention. And make sure you've controlled their other risk factors. So liaise with their GP, ensure their hypertension, if they have it, is controlled appropriately. Now, there are some procedures available which we can do for intermittent claudication. We would only really consider intervention for disabling claudication. So this is short distance claudication, which is having a huge impact on life. So in vascular surgery, there's always two options in terms of intervention. Is it endovascular or is it open? Endovascular options would be an angioplasty. So you put a wire to an area of a stenosis or through an occlusion, use a balloon to obliterate that stenosis. Sometimes you can put a stent in, but that's not as common in the lower limbs as it is, say, in the heart. Bypass surgery can also be performed. We'll talk about this a little bit later. So it's a spectrum. So intermittent claudication is a spectrum of disease, a peripheral arterial disease, which if left untreated and getting worse, will then end up with chronic limb-threatening ischemia. So these patients will have at least a 2-week history of significant pain, and especially pain at rest in their limb, and they may or may not have tissue loss. So these are ulcers or loss of tissue over their leg, or wounds that are not healing. On examination, you can do the Burgess test. So the Burgess test involves having the patient lying flat. You lift their leg up in the air. You look for 1, the angle at which the leg becomes pale and white. 2, the angle at which the leg becomes painful. And 3, you can look for other signs such as venous guttering. So this is when the veins are empty and form a gutter because there's not enough blood supply getting back up to refill them. To complete Burgers, you then ask the patient to spin their leg off the side of the bed, and you should see a reactive hyperemia due to vasodilation promoting blood flow to the foot. So investigations, the same as we discussed before for the previous slide. And management, again, conservative management is very similar. In terms of medical management, the one added thing here is you can use things such as prostaglandin analogs in some situations, such as in a vasculitis type picture. These are basically prostaglandins which cause vasodilation and can increase blood flow to the extremities. In this situation, you probably want to revascularize, and we have a quality improvement framework across the country to do revascularization within 2 weeks. So we aim to do an angioplasty, as discussed before, or a bypass. So quickly, the principles of a bypass operation. To do a good bypass operation, you want to have good inflow, so the blood vessel that you're going to take the bypass off. You want to have good outflow, so the blood vessel that the bypass is going to go to needs to not be occluded further down. And you want to have a good conduit that goes in between. Autologous conduits are better. So usually the vein, great saphenous vein, ipsilateral or contralateral, can be used as preference. Vein has better 5-year patency over prosthetic material. And also the other principle is keep your bypass as short as possible. So you want to only bypass where you need to go. So there's no point going all the way down to the foot from the femoral artery if you can easily just go to the knee. However, some of our patients will have surgery, have bypasses, they'll go down, they're in significant rest pain and they've got really difficult ulcers, and they may end up with a major limb amputation. So on to the next case. So very minimal history here. So you just quickly seen somebody in the emergency department. If you get cramping in their left leg at 20 yards, and it's really having a massive effect on their life. Lifelong smoker, hypertensive, but he doesn't really take his medications. He's had a heart attack in the past, and he thinks he's got a stent inside one of the coronaries. This is the scan that you've got, which has been helpfully reconstructed by the radiologist. So if we could have the next poll, please. What does the scan show? So a bit of an anatomy test here. So when everyone's done voting, if you can put the results up, please. Okay, so let's talk through this. So this is an MR angiogram. And most of you went for occlusion of the left common femoral artery. And then second most was the superficial femoral artery. Okay, so it's a bit slightly unfair to get you just to use one image to decide which blood vessel has gone down, but we'll just talk through from the top. So here is your abdominal aorta, divides into your common iliac arteries at L4 level. It then continues down as the common iliac artery, which then bifurcates into the internal iliac, which supplies the pelvis and the buttocks, and the external iliac artery. The external iliac artery continues down underneath the inguinal ligament, and when it comes from out underneath the inguinal ligament, it becomes the common femoral artery. So this is what we can see just here. The common femoral artery then divides into two. So it divides into one, the profunda femoris, which you can see coming off here. and then 2 divides into the superficial femoral artery. Now, if we look on the other side, on the right leg, we can see the superficial femoral artery coming all the way down here, and then popping through Hunter's canal or the adductor hiatus into the popliteal fossa and becoming the popliteal artery. If you look closely, oops, sorry, let me just go back. If you look closely on the left here, it's actually the occlusion of the superficial femoral artery that we have. Interestingly, this patient's got good collateralized blood flow because they've actually got blood in the popliteal artery here, which is filling via branches from the profunda. And actually, there's some reasonable blood getting down to the crural vessels here on the left as well. So just to summarize peripheral arterial disease, key things are you need to identify and control your risk factors. Patient needs to be counseled that if they continue to not adhere to advice from the medical team or do exercise, then they're at risk of amputation in the future. You want to ensure they've got secondary prevention on board, so really good liaising with the GP in primary care. Get the patients moving, get them to exercise, get them to get through that claudication distance and walk through it, because that will improve their collateralization and improve the chance of that limb staying with them. And then you need a plan. You need a plan of revascularization. Are you going to go endovascular or are you going to go open? So I'll just pause there for a second just to see if there's any particular questions on this topic.
Okay, so first question is, how long does it take for collateral blood supply to be formed?
So a difficult one to answer specifically. It depends where it is. In the lower limb, there's no specific time scale. It depends which artery it is, what other arteries are available. But it probably takes a few weeks, but it's not a very evidence-based answer there for you. In the upper limb, if you've got an occlusion of a vessel, there's a lot more of an anastomotic supply around the shoulder itself. So there's really good collateralization up there.
Okay, and another question. What's the main artery to the lower limb, superficial or deep? I assume that's the femoral.
Yeah, absolutely. So, so the vascular surgeons really like the deep femoral artery. The profunda femoris will get you out of a lot of trouble. But main supply to the lower leg would be the superficial femoral artery. If you've just got a profunda femoris, like in the last picture that we had, the last MR angiogram, the patient will claudicate.
Okay, and then last question. So how would you manage the patient that we just saw from the scan?
So we would assess their fitness for surgery. If it's somebody who's a good candidate in terms of cardiovascular fitness, then I would probably suggest would counsel this patient for either bypass surgery. So we could do a common femoral artery to popliteal artery bypass. Or I think an endovascular option is not suitable here because there's a long occlusion of the SFA. It's going to be very difficult to try and break a wire through all of this. So this is likely a fem-pop bypass.
Okay, great. Yeah, let's crack on.
Thank you. So now we'll move on to the aortic aneurysm. So just to define this, an aortic aneurysm is a permanent an aneurysm is a permanent dilatation of a blood vessel, which is 1.5 times its normal diameter. It's also defined by its locations, whether it's in the aorta, abdominal or thoracic, or what kind of morphology it has. So is it a true aneurysm, which involves all 3 layers of the vessel walls, so intima, media, and adventitia? Or is it a false aneurysm, also known as a pseudo aneurysm, which doesn't involve all 3 layers? A true aneurysm can also be saccular or fusiform. Again, this affects men more than it affects females. And the etiology is usually due to atherosclerosis and hypertension. These are the most common causes. But connective tissue disorders do lead to a preponderance to predispose aneurysm formation. So I'm talking about things like Lewy-Dietz syndrome, Marfan syndrome, and vascular Ehlers-Danlos. So mycotic aneurysm is a slightly misnomer, but it's a term which covers bacterial or other infective aneurysms, which again form a smaller amount of what we usually see in our daily practice. Risk factors similar to what we've already discussed, but into this you can add in trauma, which usually results in the formation of a false aneurysm. So this is blunt trauma, penetrating trauma, or iatrogenic trauma to a vessel. So the ruptured abdominal aortic aneurysm. So this is a surgical emergency. These patients usually present either in extremis with syncope, collapse, and hypovolemic shock, they often will have either back pain or acute abdominal pain. You may palpate a mass inside their abdomen, and that mass may well be pulsatile. So what do you do in this situation? Well, these are patients that you need to get into somewhere like the resus department within ED. You need to be closely monitored. You need an urgent set of bloods, including FBC, UNE, coagulation, and group and screen. I'd go as far as saying, actually, if you suspect a ruptured aneurysm, you should be activating the major hemorrhage protocol. Anybody with acute abdominal pain, especially males over the age of 55, you need to think about the aorta. And it's usually good for the emergency department team to perform a quick ultrasound scan. So these are also known as fast scans, where you can pop a probe on the abdomen just to see if there is an aneurysm. And if there is, the patient should head straight for a CT scan if they are hemodynamically stable. So how do you manage this then? Well, airway, breathing, circulation, get help. You need as many people around you as possible to give you a hand in managing this acutely unwell patient. You need the vascular surgeons there, and you want to get the interventional radiologists to start looking at any kind of imaging that you may have. So what's the conservative management for this? Well, it's basically palliation. So this is somebody who's not fit for surgery and just is for symptom control, and this will be a terminal event. Medication-wise, well, there's nothing specific, but you just want to make sure their BP is controlled, that they're not hypotensive, that they're not perfusing their brain, and they're not very hypertensive, that they're increasing their risk of exsanguinating their blood volume. And then we move on to repair. So there are two broad ways we can repair an aneurysm. Again, it's either via an endovascular approach or an open approach. An open repair would involve a laparotomy, stitching in a graft above the aneurysm and below. This is usually associated with initial higher morbidity and mortality than an endovascular aneurysm repair, but is usually a more durable repair in the long term. Endovascular aneurysm repair can actually be performed percutaneously through incisions in the groin, and we basically deploy stents to exclude the aneurysm itself and create a nice new pathway for the blood to flow. I won't get into too much of the specifics of when you choose which approach. Both have their pros and cons. Endovascular repair usually has a much higher incidence of re-intervention after about 5 years. Most of our aneurysms come to us through incidental findings and through screening programs. So in the NHS in the UK, we have a single ultrasound scan offered to men aged 65 to screen for an aortic aneurysm. If there's one found, then they get a CT scan and then they get referred to the vascular surgeons. We would often monitor an aneurysm which is less than 5.5 centimeters. We would monitor regularly with duplex ultrasound. And once it hits 5.5, we would offer repair. At this point, the risk of rupture outweighs the risk of proceeding with intervention. So conservative management, monitor. Medical management, control any hypertension. And surgical management, well, same as before, you can do an endovascular or an open repair. So here's a case. You've got a patient who you've just seen in ED resus, acute onset back pain, but they're alert. They're speaking to you, they're giving you a good history. Their systolic BP is 95 millimeters of mercury, heart rate's 90, and they're in sinus rhythm. Can we have the next question, please? And this is their CT scan, which I'm sure you've had a look at already. So what do you do in terms of their fluid resuscitation? Right, okay. So most of you went for a 500 milliliter fluid bolus. Right, so there's a concept which we follow in this specific scenario, which is a concept of permissive hypotension. And this is a bit of a naughty question I've put in here. For this patient, we would aim to have a systolic BP of around 90 systolic would be fine, as long as they're alert and they're talking to you. The risk of aggressively fluid resuscitating this patient is they may have formed a clot, which is slightly sealing the rupture. If we go ahead and increase their blood volume drastically, they may well dislodge that clot and bleed out entirely, in terms of into their intra-abdominal compartment. So for this patient, we would probably hang fire as long as they were not showing any other signs of hemodynamic compromise and watch them closely. Of course, we would activate the major hemorrhage protocol just so the blood was there with the patient, but we may not give it. And just a little few minutes on how do you get a patient to theatre. Well, so if we think about our patient here in resus with a rupture, your consultant comes down and says, sort this patient out, needs to go to theatre now, but has to rush off to an emergency. So what are the actual steps that you need to take when you're on the on-call? Well, first of all, you need to put a case request in. So it depends on where you work. This can be done electronically or via a written request. You need to take this case request to the emergency theatre coordinator. You want to ring or see the emergency theatre coordinator, explain to them this is a ruptured aneurysm, it's an urgent case, it needs to come within the next X amount of time, it's usually straight away for a ruptured aneurysm, and ask them to get a theatre prepared. You then want to contact the anaesthetist who is in charge of the emergency theatre, just to inform them of this patient so they can start making an assessment. The massive transfusion protocol should hopefully have already been activated for this patient. Somebody with appropriate skills needs to gain consent if the patient is with it. They can use a consent form 1. If the patient's deteriorating significantly, then a consent form 4. And it's also very important always to keep the family in the loop about what's going to happen. So I'll pause there for some questions if there is any on this topic before I move on to my next case.
Okay, yeah, we've got a couple. So is a pseudo aneurysm just bleeding between the externa and media, or is there more to it than that?
So the easiest way to define a pseudoaneurysm is it's an aneurysm, a dilatation of a blood vessel which does not involve all 3 layers. So it can be any combination, basically. Okay,
great. And can an aortic aneurysm reduce on its own if it's below 5.5 centimeters? If not, why are we waiting till it's 5.5 centimeters to operate?
Good question. So I don't think anyone's seen an aneurysm reduce in size before. It may well just stay stable. We have a lot of patients who have a subthreshold aneurysm, which we're monitoring for a long time, and it's nice and steady. The next part of the question is, why wait till it's 5.5? Well, as the aneurysm increases in size, its risk of rupture in 12 months increases pretty exponentially. The research shows that below 5.5 centimeters, the risk of rupture is actually quite low. And the risk of intervention by doing a really invasive operation like an open aneurysm repair or an endovascular aneurysm repair, the risk of that and the morbidity and mortality associated with that intervention is higher than the risk of rupture, in which case we will not offer that treatment in the UK.
Okay, and a couple of people asking, I think the answer to the last question was to not fluid resuscitate and to aim for around 90-ish, which is permissive hypertension. And then, sorry, one last question. Would it be necessary to perform imaging before the repair of a ruptured aneurysm? What if there's no time?
Yes, so very good question. So you have a patient. If the patient's stable, we will try and get a CT angiogram done. And the reason is if we want to perform an endovascular aneurysm repair, we need imaging. You cannot perform that without a CT scan because you need to do various anatomical measurements to size your graft. If the patient's unstable, you forget about endovascular aneurysm repair, you go straight to theatre and you go for an open repair.
Okay, great. Let's move on.
Thank you. So we're just going to do another case now. So this is a case. So there's a patient who's on the ward. They've had a cardiac intervention, so something like a coronary angiogram done. They've used the left groin as an access site, so they've done a common femoral artery puncture and used that to get to the heart. The nurse asks you to come and assess the patient because they've got a swelling in the left groin, which patient says is getting bigger. You examine it, tender to touch. Patient's blood pressure has been slowly dropping and they're scoring a bit on their news too. And actually the last set of bloods that you checked, the HB was on the creep down. You very astutely perform a CT scan, and very helpfully somebody's put some arrows on this scan to show you where the pathology is. So if we could have the next question, please. What is the diagnosis? Yeah, good. So there's a split, which is what I was hoping for. So the diagnosis here. So 43% of you went for a false aneurysm, or pseudoaneurysm, as it is also known, and 50% of you almost went for a hematoma. Now, there is a hematoma here, which is denoted by the white arrow here. This is a hematoma, which has been measured. But the key thing here is the history of an intervention of the common femoral artery with a puncture, which has caused trauma to the blood vessel. What we have here is contrast. So this is contrast. And you can appreciate this contrast is not within a nice circular lumen of a vessel. So this is contrast, which is extravasating into this region of the body here. So this is a pseudoaneurysm or a false aneurysm. And these are things that you will have to look for in a patient who's had any endovascular intervention, whether it's through the groins or through the radial arteries. And it's a common thing that you'll see on the ward post-operatively. A pseudoaneurysm is one thing. A hematoma is the other thing. So you're right, that is one thing that it could be. But here, the single best answer is a pseudoaneurysm. So what is a false aneurysm or a pseudoaneurysm? I think this picture shows things quite nicely. You know, it can also show us one way of treating this. Well, we've talked about the definition. If you've got a small pseudoaneurysm with a neck that's quite thin, you can do many things. So one of the things you can do is you can get an ultrasound probe and you can press on the neck, occlude the neck, and try and get it to thrombose. So that's a pretty minimally invasive intervention. You can use ultrasound guided injection of thrombin. So you can actually puncture this with thrombin, which is a procoagulant, and cause it to clot off. So those are sort of two less invasive ways of dealing with a pseudoaneurysm. Now, if the neck of the pseudoaneurysm, the bit that's damaged and connected to the cavity, is large, then you can't usually do this. At which point we'll have to think about surgical repair. If we think back to our previous patient with this very large pseudoaneurysm, with hypotension and a dropping HB, these ultrasound guided methods are not appropriate here. This patient requires urgent intervention. So what do you need to do when you're on the ward? Assess this patient ABC, get some oxygen on, get some fluid running. And the key thing here is to apply direct pressure. If you've got a wound that's bleeding on a vascular surgery ward, the most important thing you can do is take something, your hands, pair of gloves, and some gauze, and just apply direct pressure. That's the easiest and the best thing you can do, and call for help. That pressure will stop anything expanding and stop this potentially rupturing and having the patient lose a significant amount of volume. Your FY2 or your SHO comes along and can help you do things like cross-match for this patient. So how do you treat a pseudoaneurysm? Well, you would do an open repair, for example. So you'd make an incision over it. You'd find the area that's damaged and you can put a stitch through that just to close the defect. Sometimes these can become infected. So say you've got an intravenous drug user who uses the vessel to inject regularly and they have an infection. They might need to have this vessel completely ligated. So you have to go above and below and tie the vessel off completely. Any questions about this before I move on to the next?
Yeah, so how do you distinguish between a pseudo and a true aneurysm on CT?
So yeah, good question. So on a pseudoaneurysm, you'll see a nice, well circumscribed wall if it's not infected. A pseudoaneurysm, you always see this little neck. So let me show you on this. So we use this picture. So you can usually define the neck of the pseudoaneurysm, and then there's a very large abscess, a very large hematoma cavity associated with it. So the images are quite distinct on a CT scan.
Okay, great. And so could you just repeat, what scenario did you say you would apply pressure to a pseudoaneurysm?
So to a pseudoaneurysm or any wound that's bleeding on a vascular surgery ward, just apply pressure.
Okay, great. That's easy to remember. And how much blood should be cross-matched for a pseudoaneurysm?
Yeah, good question. So I would suggest 2 units for this case initially, and then you can always request more if there's a HB drop in theatre. It's just good to be prepared.
Okay, great. Thanks.
So we'll just quickly talk about leg ulceration, and I've just got a few pictures for you at the end before we tie everything up. So leg ulceration, there's three main types that you need to know about in vascular surgery. So venous leg ulcers, arterial ulcers, and neuropathic ulcers. Of course, there are those patients who have mixed pathology, but we won't cover that today. A venous leg ulcer is classically associated with chronic venous insufficiency, so whether they've got superficial reflux or deep venous reflux. You'll find them most commonly in the medial gaiter region. So if you remember your medial malleolus, it's usually around about there. Chronic venous stasis causes deposition of hemosiderin, as you can see here, which is the dark discoloration. You get persistent inflammation, which can then lead to venous eczema and skin changes. And as this progresses over a long time, you get scarring of the tissue, which leads to a thinning of the area here with swelling above, which gives you an inverted champagne bottle appearance. The wound itself will not be very well circumscribed and be quite superficial and have some granulation tissue in between. An arterial ulcer is because of reduced blood supply, as we've discussed already. So these ulcers are often just well circumscribed, maybe described as punched out ulcers, and are commonly associated with a lot of pain. So the patient will have a lot of pain in the ulcer itself and usually distal to it. You may see some signs of necrosis of the skin, so black areas where things aren't quite doing so well, and there may also be some superseded infection. A diabetic foot ulcer, or also known as a neuropathic ulcer, is usually common in diabetic patients who have peripheral neuropathy. The peripheral neuropathy means that if they have a traumatic injury to the foot, they can often not feel it. And what we usually often see is problems with the sole of the feet. So they may have some gravel in their shoe, which they haven't noticed, and they've been walking on it for a long time. Or they've got ill-fitting footwear, and they've got a neuropathic ulcer on the tip of their thumb, toe. The toe. Combine that with the fact that they're going to have significant vascular disease, a lot of microvascular disease with diabetes and calcification, which causes ischemia. So next poll, please. This is going to be three very quick pictures to see. What type of ulcer is this? Very good. Neuropathic. Mostly you can get that from the distribution of it, where it is in the pressure area. There's a little bit of pus in there as well, so this looks to be infected. And it looks like the patient's in theatre as well, so they're probably going to do a bit of double debridement there. Again, next poll, please. What kind of ulcer is this? So interesting. So we went for an arterial ulcer here, and some of you went for venous ulcer. So there's a bit of a split. So this is actually a venous ulcer here. So it's sort of, the edges aren't very well circumscribed. Around the skin itself, you don't actually see very many skin changes here in this particular patient. Also remember that skin pathology presents slightly differently in terms of appearances with darker skin. But I can appreciate here, there's some thread veins up here, which suggests this is a venous pathology. There is a little bit of darkening of the wound edges, and there are some thread veins just over here as well. So this is actually a venous ulcer. And what about this one then? I assume there's not very much variability in the answers here. And you can compare this to the previous picture. So yeah, arterial ulcer. The giveaway obviously is the necrotic black toes because of ischemia, but this is a well circumscribed ulcer which looks to be punched out. There is dead skin in the dead tissue here in the middle, and there's surrounding sloughy infection here as well. So is there any final questions? I've just got one slide left to go just on vascular surgery training itself, the pros and cons of it, and how to get into it. But if there's any final questions on the content, I can answer them now.
Yeah, so someone asked, what is hemosiderin?
So hemosiderin is, so you get hemostasis, you get venous stasis, with the stasis of the blood in the veins, and the hemoglobin is broken down. So the heme in the hemoglobin is deposited in the skin, which is hemosiderin.
Okay, great. And so what's the common position of arterial ulcers if venous are usually on the medial malleolus?
Yeah, so remember, we're talking about the most common positions. So if you think about a patient who's got ischemia because of a stenosis or an occlusion, the arterial ulcer would usually be at the point that's furthest away from your heart. So the point that it's going to take a lot more effort to get blood to. So you'd often see these on the toes. So little ulcers on the tips of the toes is usually where they start, and then they come proximally.
Okay, great. And yeah, sorry. What's the pathophysiology of shiny skin in peripheral arterial disease?
So I think in terms of that, I think we're probably alluding to the hair loss. So as far as I understand, the hair loss is because of the ischemia, and you get death of the hair follicles, which is why you lose your hair. I don't know about the shiny skin part, to be honest.
Okay, great. Would you like to do your last slide, and then we can mop up maybe if we've got time at the end with some more questions?
Yeah, sure thing. So in terms of, it's just a quick slide on vascular surgery and why vascular surgery is a really good specialty in my opinion. So as a vascular surgeon, you can operate pretty much anywhere in the body. So any blood vessel is under your remit, with the exception of the heart, which we lead with cardiothoracics, and the brain, which is usually under the remit of the neurosurgeons. You get dual training in endovascular surgery now. So we do a lot of interventional radiology work in collaboration with IR and also independently. If you go to a hybrid theatre, it's pretty cutting edge stuff. It's really, we've got high technology, we've got mobile C-arms, we've got the capability of performing CT scans on tables such as Dyna CTs. The work itself is a lot of acute work. So about 60% of our day would be acute admissions. And often with the surgery itself is either limb or life-saving. The surgery itself is technically challenging, especially the open procedures. So you do require a higher degree of finesse and training and sort of respect for tissues and instruments. But it doesn't all just end in the operating theatre. As you've probably figured out from my slideshow so far, our patients are not just a one pathology patient. They have multiple comorbidities. You need to know how to treat an MI on the ward. You need to know how to treat COPD. You need to know how to treat all these other pathologies to get the best for your patient. In the clinic, you need to know which medications they need to be given for secondary prevention. Otherwise, you'll just see them again in a year's time with a worse outcome. And we usually have a really big multidisciplinary team. So we work very close with interventional radiology. We work close with the diabetologists on the medical wards, really closely with the podiatrists, and also the vascular studies lab. So it's a very big team, lots of input, and a good specialty to be in. Entry is the same as other surgical specialties. So the most common way is through ST3 entry. So you do your core surgical training and enter as ST3. There's also IST entry as well at ST1. So this gives you a run-through training number. And there's an academic pathway through vascular surgery. Vascular is a pretty academic specialty. There's a lot of cardiovascular research that is done by the surgeons. You can do an academic clinical fellowship, such as I've done, starting at ST1 with a run-through number, or you can progress on to do academic clinical lectureship further on down the line. In terms of how this specialty training looks, well, the first year as ST3 is usually in general surgery. So you do a year of open general surgery, concentrating on procedures within the abdomen, bowel resections, hernia repairs, that kind of stuff. And then the rest of your training, you concentrate on your vascular and then your endovascular skills. If you're interested in that, I would highly recommend you join the Rouleaux Club. It's free. We are the UK Vascular Trainees Association. We're very keen to have representation from medical school through to SHO, registrar and above. We also run some webinars every 2 weeks. If you've got interest in what you've heard today, you can listen to these to give you a lot more background information. And I'm very happy to answer any questions you may have. You can just find me on Twitter and drop me a message if you've got any specific questions about anything. Back over to you, Lawrence. That's my slides done there.
Okay, great. Thank you so much for the lecture this evening. That was really fantastic. Okay, so I think this is, forgive me to whoever's asked this, but I think this is going back to the pseudo aneurysm slide where you mentioned that you could ligate above and below an artery.
Yeah.
So someone's asked, if you have to ligate the vessel, like the common femoral, would there be collaterals present to supply the rest of the leg, or what would you do about that?
Yeah, so it's a very good question. Ligating a blood vessel is usually the last thing that we want to do. Now, so whether there be collaterals depends on the pathology. So if we think about somebody who is an intravenous drug user, who continually injects into their groin, who probably has distal embolization of whatever it is that they're injecting into their groin anyway, they are likely to have collaterals. So when they come in, we usually ligate their common femoral artery, plus minus other vessels in that region. And they generally do okay because they've had a lot of chronic problems. They've built up that collateral blood supply. Now, somebody who doesn't have any peripheral vascular disease, if you were to go and ligate their common femoral artery, they would be in real trouble. So they would probably present within hours of post-op with an acutely ischemic limb. In that situation, if the patient is stable, the field is not infected, you can just do a graft. You can just put a little bit of material, a bit of vein, just to cover the area where the problem is. Or you can do an extra anatomical bypass. So you can just do a bypass above and below the region, and then that would then restore blood supply.
Okay, great. And so how are the lower limbs perfused during AAA repair when the aorta is clamped?
So not very well is the answer to that. So you obviously know the anatomy. So if you've got the aorta clamped, there's not much anything getting past into the legs. So the legs can survive up to about 4 hours or so before they start getting signs of ischemic damage. So this is why it's really important when you're performing abdominal aortic surgery to liaise with your anaesthetist. When you take the clamp off and reperfuse one leg, so we do one leg at a time, you're going to have 3 hours or so of metabolites which are going to come back and hit the heart. So you tell your anaesthetist in advance, they get ready for that ischemia reperfusion injury, and then you just release slowly and sequentially.
Okay, and I think we'll just do 2 more if that's okay.
Yep.
So can you describe the difference between gangrenous and necrotic tissue?
It's essentially the same. Both words are used interchangeably.
Okay, great. And then a last question about sort of careers and stuff. So how competitive is vascular surgery? What extracurricular things would you recommend to a medical student?
Yeah, sure. So so all surgical specialties at ST3 are competitive, but vascular surgery isn't on the level of sort of cardiothoracics and neurosurgery in terms of competitiveness. We've got quite a few more posts available. So I would suggest vascular surgery is akin to getting into general surgical training in terms of how competitive it is. What you can do in medical school is you can just show interest, sign up to the Rouleaux club and do the essay competition, for example, shameless plug. You can also do things like an audit, quality improvement project. You can do a small research project. All of these things show your interest in a surgical career and would look really good on your application form going forward. Listening to these kind of webinars, getting certificates as evidence that you've attended this particular webinar is also really good, and it shows that you're engaged.
Okay, great. I think we're just past 8 o'clock now, so I think we'll call it there. But thank you very much again for a fantastic lecture, and thank you guys all for tuning in. If you haven't already, just a last reminder to fill out the feedback, and thank you to those who already have. That's all from me, and yeah, quite a few people just saying thank you in the chat as well.
Thank you very much everyone for listening. I really appreciate it. Thank you.
Okay, great. So that's all from me. I think we'll end it there. Thanks, guys.
Bye-bye.